Hi, my name is Gary Brown, and this is my Pdsa presentation, Increasing Enrollment in Diabetes Education and Support Programs for Nursing Leadership Practicum Nursing 451. Pdsa cycle. Problem identification. Diabetes education and support groups can lead to improved disease management for patients with diabetes. Patients are not consistently being directed to my hospital's provided diabetes education and support group. Research supporting increased diabetes education. One study realized that patient education is an integral component of high-quality diabetes care. The National Diabetes Education Program stresses the need for patients to have a practical understanding of approaches to self-management of diabetes and related conditions. It was further seen in another study that it is possible to produce sustained improvements in clinical outcomes and reductions in healthcare costs for patients with diabetes using a chronic care model that provides frequent follow-up visits. High-quality diabetes self-management education, DSME, and diabetes self-management support, DSMS, have been shown to improve patient self-management, satisfaction, and glucose control, according to the American Diabetes Association. And further, a Dutch study determined that when it is not possible for patients to physically attend education and support groups, that online education is easily accessible, can be interactive, and can be adapted to individual characteristics based on, for example, learning needs or educational levels. Quality variance. I was surprised to discover that in my hospital there is no codified set process for directing patients into our diabetes education and support group. There are many hands in the pot, so to speak, but there is no one individual process. We have social workers, we have individual nurses and doctors, and we have our discharge advocates. But no one person is responsible, and there's no one set system to direct people into these classes. So I think we're getting a lot of fallout in that regard. There are many readmissions for uncontrolled or poorly controlled diabetes in my hospital, and this is from my personal experience, recognizing patients as they're readmitted and seeing that, once again, that their diabetes is out of control and they're suffering the ill effects of that. And then I took a look at Medicare.gov to see how we're doing in terms of directing people to manage their disease or their recovery once they're discharged from the hospital. And although we're not doing terribly, we're definitely underneath the national and California average at 84%. According to the standards set by the American Diabetes Association that were updated in 2015, people with diabetes should receive diabetic self-management education and diabetic self-management support according to the national standards when their diabetes is diagnosed and as needed thereafter. Effective self-management and quality of life are the key outcomes of education and support and should be measured and monitored as part of care. Education and support should address psychosocial issues, emotional well-being, and is associated with positive diabetes outcomes. Education and support programs are appropriate venues for people with prediabetes to receive education and support to develop and maintain behaviors that can prevent or delay the onset of diabetes. Because education and support can result in cost savings and improved outcomes, these should be adequately reimbursed by third-party payers. Stakeholders. The number one stakeholder in this entire enterprise are patients and families. The lack of proper education and support leads to negative health consequences that affect both patients and their families. Increasing enrollment through an automated or structured process will improve outcomes. Doctors, nurses, social workers, and other healthcare professionals. It'll take a team effort to develop and implement a process which increases enrollment. Nurses will be primarily responsible as the point of contact to enroll patients into the new process and to verify that they are enrolled. Hospital administration. I think administration would be very concerned about recouping some of the revenue that's lost having to do with readmissions. So this could be a source of savings for the hospital. Root cause analysis. We need to change the care system. Optimal diabetes management requires an organized, systematic approach and the involvement of a coordinated team of dedicated healthcare professionals working in an environment where patient-centered care, high-quality care, is a priority. That's according to the American Diabetes Association. And further, there's a lack of online information provided by my facility. The entirety of the information regarding the Stuck in Lodi, the Diabetic Education and Support Group for Lodi, states that Stuck in Lodi is a diabetes support group that is held the first Monday of every month. Topics will focus on living and living well with the disease. There is no other information online, and the point of contact is an email address which I attempted to contact and received an automated reply that the individual would be out of the office for an extended term. There was no follow-up information. There was no recontact after that point. So we're failing in that regard. And then, for example, our national rate of all hospital-wide readmissions, including diabetes and other things, is no better than the national rate, 15.6%. So we're not doing terribly, but we definitely have room for improvement. Solution. We create a unified, streamlined, automated process of enrollment for diabetes education and support. And I believe this should be integrated into our electronic health system, our electronic health record. We would start with our unit-based council, which is a gathering of nurses, social workers, essentially any healthcare professional in the hospital that works on the floor and can propose new ideas, make suggestions, and essentially it's a think tank for generating change. With the unit-based council, we could make a draft proposal. If this is well received, we would engage a physician advocate, and then we would make a formal proposal of this change to the administration. Once we were green-lighted, we would integrate this new system into our Cerner electronic health record, which we are in the process of integrating and rolling out right now. So this will be a big change for us. We're moving on from an older electronic health record program that doesn't have a lot of capacity for making changes into Cerner. Cerner, as I've discovered, has a comprehensive web-based patient tool and education service called HealthLife. And I think that we could make something that works in conjunction with that. Once this was ready, we would have in-service education for nurses and doctors and the other healthcare professionals to familiarize them with the system so that they could ask questions and learn to navigate the process. And this should be a two-pronged approach for our patients. Number one, we need in-person classes and support groups, and we need to expand those. But further, we need to offer online education and communication and support for people who either lack transportation or simply don't have the means to come to a physical class or support group. Implementation. So the new system would automatically prompt the nurse to enter or verify contact information for patients when they're admitted with diabetes or diabetic-related conditions. Flags would appear in the electronic health record for nursing, case management, social workers, and diabetes educators. These flags would indicate to these people that this individual needs to be diverted into education and support and given information about online education as well. As part of discharge, patients would be enrolled in classes and support groups just as they're now scheduled for follow-up appointments. So we need to make this part of our discharge routine to ensure that everyone who needs this education and support and information is in the system. Further, patients that are unable to arrange transportation, they would be diverted into the online diabetes education systems. Analysis. How do we know if this is working? Well, number one, according to the American Diabetes Association, we need to track A1C. For those who seem to have good, stable glycemic control, we should test at least 2 times a year. For those who are not meeting glycemic controls, not at their goal, They need to have quarterly tests, and that can give us a good idea of if our diversion program is working, if our education support is working, or if things need to be changed. Further, we need to survey our patients. We need to conduct feedback surveys to evaluate the effectiveness of education and support. And the online diabetes education study that I took a look at, they used a simple survey to see how people with diabetes responded to the online education. It wasn't complex, it was easy to fill out, and that probably increased the amount of feedback they got. For example, their survey for program content, the question was, what is your opinion about the content of the website? Straightforward. What information could you not find? And I think that's just as important as the information we do provide. We need to know if people are looking for things that they're not getting, and then maybe we can try to fill that need. User-friendliness. What do you think about the user-friendliness of the website? And what do you think could be improved? And this is important because my facility has a large percentage of elderly, and these people may not be as familiar with the online environment. So making sure that our program for online education and support is user-friendly is very important. Program goals. What do you think about the website's goal, or what do you think the website's goal is? And do you think that these goals are achievable? So that's important too. This feedback can help us make changes and edit what we offer in terms of education and support, both in person and online. And tailor that in a sense to meet the goals of our patients. Further, for analysis, we would track readmissions just as we do now, see how readmissions are being affected by the education that we provide, and we could audit the enrollment compliance with the new program. Act. We would need ongoing unit-based council feedback and recommendations to improve the process of enrollment, and also to determine if the education and the support is being effective. Quarterly audits of patient enrollment numbers in diabetic education and support groups. We need to expand the number of classes to meet increased enrollment. We need to offer a award and recognition program for nurses and other staff maintaining compliance with the new program. And probably even more importantly, an award and recognition program for patient involvement in these programs. If these things are successful and we do see improvements in the diabetic education and support, if it leads to better management, decreased readmissions, then we could propose to roll this out organization-wide throughout Adventist Health affiliated hospitals. And these are my references. Thank you very much.